Good day, dear students. My name is Abou, Professor of Internal Medicine. I'm in the Rheumatology and Clinical Immunology Unit, and today we will be speaking about spondyloarthritis. First of all, we'd like to start off by defining what is spondyloarthritis. This term is derived from two Greek words, spondylo, meaning vertebrae, arthra, meaning joints, and the third, itis, meaning inflammation. It's a multifaceted systemic disease. We should know that it encompasses inflammation of the axial skeleton, which we call axial SpA or spondyloarthritis. From now on, SpA will stand for spondyloarthritis, and extra-articular symptoms such as psoriasis, uveitis, inflammatory bowel disease, and also other articular extra-axial manifestations and peripheral articular involvement. So, in other words, we can say that the term spondyloarthritis refers to a group of heterogeneous conditions which share common etiopathogenic and clinical manifestations. Spondyloarthritis is characterized by chronic inflammation affecting musculoskeletal sites of the synovium, synovitis. Entheses, we know entheses is the site of attachment of a tendon or ligament to the bone, and also extra-articular targets such as the uvea and the aortic valve roots. So when you think of spondyloarthritis, you should think of them as a group of disorders that share articular, extra-articular, and genetic features. They have a strong predilection to the spine, especially the sacroiliac joints, and that is why the commonest symptom will be low back pain, often associated with a genetic predisposition HLA-B27. In most cases, the patients are negative for rheumatoid factor, and that is why we had the old name, seronegative spondyloarthritis, and there tends to be a familial tendency. As you see, we said they are a heterogeneous group of diseases. So they are a family of rheumatic diseases that share clinical features, synovitis and enthesitis. Again, we reiterate genetic predisposition is present, especially with HLA-B27, usually RF negative, and divided into axial and peripheral spondyloarthritis. As you see, these are the different entities. Maybe axial spondyloarthritis, reactive arthritis, undifferentiated psoriatic arthritis, inflammatory bowel disease related arthritis, and when it occurs in individuals less than the age of 16, we call it juvenile spondyloarthritis. And at the heart of these conditions is, of course, the axial spondyloarthritis, which is the expanded concept of what we used to know as ankylosing spondylitis. So when you think of spondyloarthritis, you should think of it as a spectrum where we have axial involvement, and the axial involvement includes the spine or the sacroiliac joints, and this is further subdivided, as we will see as we go along, into radiographic axial spondyloarthritis and non-radiographic axial spondyloarthritis. And we also have the peripheral spondyloarthritis involving the peripheral joints, and this includes diseases such as psoriatic arthritis, reactive arthritis, IBD-associated arthritis, and the undifferentiated peripheral SpA. So once again, we see the different heterogeneous groups. Axial spondyloarthritis with the axial manifestations, which is subdivided into the radiographic axial spondyloarthritis, what we used to know as the ankylosing spondylitis, and the non-radiographic axial spondyloarthritis. And the peripheral manifestations, which, or the peripheral SpA, which includes psoriatic arthritis, arthritis associated with IBD, reactive arthritis, and the undifferentiated SpA. So once again, we say spondyloarthritis are heterogeneous entities where they share clinical, laboratory, and imaging features. And we'll see these one by one as we go along. So when you think of axial spondyloarthritis, or spondyloarthritis in general, it's a spectrum of diseases under the umbrella of spondyloarthritis. Sometimes, as you see, there may be overlapping features, we may have peripheral and or axial manifestations present, and we may have a combination of features, and they share genetic features. When we go back into the history, we will see that previously we just used to think that spondyloarthritis was ankylosing spondyloarthritis, which is the most severe form of spondyloarthritis, of what we know now as radiographic spondyloarthritis. It was established many, many years ago in the 19th century, further well established in the mid-20th century. HLA-B27 associated is just about 50 years since it was discovered, and it's been long known as ankylosing spondylitis. And we know that if we do not treat the disease, it progresses. And as you see in this same individual, over the years, progressive deformity and full-blown ankylosing spondyloarthritis over a period of about 36 years. So this was the old concept that we had, that it was just one disease, ankylosing spondylitis. It used to occur, we know that it commonly occurs in the young. We used to say it was very, very common in the males, and it always involving the spine. Now we know that males and females can get spondyloarthritis. We know it's a global disease, and as we'll see in a minute, it may be non-radiographic. What do we mean by non-radiographic? When we look at a plain X-ray and we look for sacroiliitis, we cannot see it on a plain X-ray. So we have to do further advanced imaging. And we know that around the world, even in our country here, it is around 1% of the population worldwide. So when you are asked what is SpA, it's a group of chronic immune-mediated inflammatory diseases, overlapping clinical and genetic features, heterogeneous presentation, inflammation particularly involving the axial, spine, and or the peripheral joints as well, and it is associated with many extra-articular manifestations as well, as we'll see in a minute. So if we want to classify axial spondyloarthritis, how do we do that? It's, as I said in the beginning, we have two types. Axial spondyloarthritis may be non-radiographic or radiographic. What do we mean by non-radiographic? When we do an X-ray on the sacroiliac joints, the X-ray does not show damage. So we see no damage, no signs of inflammation on the sacroiliac joint or in the spine. Therefore, we do further advanced imaging. We do an MRI, and here we may see inflammation of the sacroiliac joints and or the spine. So this is non-radiographic. What do we mean by non-radiographic axial SpA? No features are seen on a plain X-ray, but features may be seen of inflammation on the MRI. Radiographic axial SpA is what we know as the ankylosing spondylitis, which is the severe form of spondylitis, where we see X-ray changes. The plain X-ray shows damage to the joints and the spine. And also, when we do an MRI, we see inflammation. So, as you see, it's a spectrum of disease. In the beginning, it may be early axial SpA, very mild manifestations on the sacroiliac joint, which are not seen on the plain X-ray. That is why we do magnetic resonance imaging. We do an MRI, and if we do not treat the disease, it may progress to a severe form where we get severe erosions and ankylosis and full-blown ankylosing spondylitis. So as you see, it's a progressive disease, non-radiographic. The patient may just come presenting with back pain. We do a plain X-ray, no manifestations on the X-ray, but we see manifestations of inflammation, sacroiliitis on magnetic resonance imaging. As the disease progresses, the patient still complains of back pain, and then we start getting radiographic changes even seen on the plain X-ray. And of course, further with time, we get more and more damage. So it is a concept. The concept is that we have two forms of axial spine, the non-radiographic and the radiographic. In the non-radiographic, you just have clinical manifestations of axial SpA, but no radiographic evidence of structural damage. The magnetic resonance imaging may, at this point, show active sacroiliitis, but the plain X-ray does not show any form of inflammation. And what is important to know is that not all patients with radiographic sacroiliitis will progress. Only a very small percentage will progress to the full-blown radiographic axial SpA. So as you see, it is a continuum. So when will my patient progress? We ask ourselves. In general, we find that it progresses in less than 20% of patients over 5 years. What are the risk factors for progression? If your patient has got a strong genetic predisposition, if he is HLA-B27 positive, if he's got inflammatory markers, particularly elevated CRP, if on the imaging you find low-grade radiographic changes, structural changes on the magnetic resonance imaging even at baseline, and active sacroiliitis on the MRI, these are all risk factors for progression, as is the smoking status. If the patient is a smoker, it's a very important risk factor for progression, as well as an extra articular manifestation, which is uveitis, and it may even be previous uveitis. Here you see how the condition of axial spondyloarthritis may progress, and how over the years the patient becomes completely bent over and cannot even see the sun. He cannot do his daily activities. As I said in the beginning, there's a lot of overlap between the different forms of spondyloarthritis, and patients may have various overlapping. You don't have to know the particular percentages, but you do know that previously we thought it was just one single disease, but now we know that it may be one disease with very different phenotypes, different presentations. Is it common? Well, axial SpA, as I said, is relatively uncommon and is likely to be the cause of long-term pain in only a very small percentage of patients. We know that many patients around the world can get chronic low back pain, but chronic low back pain as a cause of axial SpA is relatively uncommon. So how will the patient present to you? He will come to the clinic saying, "My back hurts." That's the commonest presentation. So we should know that 20% of people aged between 20 to 59 do get chronic back pain. Not all chronic back pain is due to spondyloarthritis. 1% of the adult population only are affected by axial spondyloarthritis. The peak age is young age, between the 20s and 30s. That's the common peak age of onset. And contrast to what we used to say, the radiographic axial spondyloarthritis is commoner in males to females. That still remains. The ratio is around 2 to 3 to 1, so 3 to 1 or 2 to 1. And the non-radiographic axial spondyloarthritis is equally common in males and females. This was not previously recognized. This is what we have known in the past 2 or 3 decades, that the non-radiographic is equally common in males and females as well. So we said the commonest presentation is back pain. So we should know that back pain is the commonest presentation, but we should know how to differentiate between inflammatory back pain and mechanical back pain, which is very, very common. Most of us have complained of mechanical back pain. So what are the criteria of inflammatory back pain that you should ask about in your patient? First of all, as we said, the age. The age of onset is often prior to 40, prior to the age of 40, 45. It's got a gradual onset. The back pain comes on insidiously. The back pain improves with exercise and gets worse on periods of inactivity. It gets worse after the patient rests. This is in contrast to the mechanical pain. The pain is worse at night, maybe in the middle of the night, nocturnal pain. the patient wakes up with severe back pain, and the patient characteristically says he's got prolonged morning stiffness. In contrast, mechanical pain usually comes more with advancing age. It's got an acute onset, it's worse during activity and becomes better after periods of inactivity, and may be associated with neurological manifestations. So if you want to recapitulate on the differences between inflammatory and mechanical back pain, we should always think of this table. Age of onset, young age of onset, older, rapidity of onset, here it's insidious, chronicity. It's very important that not any low back pain will be inflammatory back pain. It has to be for a period of more than or equal to 3 months. As I said, nocturnal pain is common. Exercise improves the pain, rest aggravates it. Morning stiffness is persistent, often more than 30 minutes. Very good response to non-steroidals, and the low back pain may affect any part of the spine. It may cause alternating buttock pain, but does not radiate into the legs. No neurological manifestations. We've had many criteria over the years to help us diagnose spondyloarthritis. One important set of criteria include the modified New York criteria that were put in 1984. Here they gave us clinical criteria and radiological criteria to help us classify our patients, not necessarily diagnose our patients. The diagnosis is more of a clinical diagnosis. What do the clinical criteria say? Any patient having low back pain and stiffness for more than 3 months that improves with exercise, is not relieved by rest, has limitation of motion of the lumbar spine in both the sagittal and the frontal planes, and has limitation of chest expansion relative to the normal values that we know that we correlate for the normal age and sex. These are the clinical criteria, and we also have the radiological criteria, which are sacroiliitis, and you will take this when you go to the radiology. They grade it. If it's a sacroiliitis more than or equal to grade 2 bilaterally or grade 3 to 4 unilaterally, then that's an important radiological criteria. And we used to define a definite ankylosing spondylitis if we had one radiological criteria and at least one clinical criteria. But then this has moved on, and as I'll show you, we've got new criteria. So just to come back to the inflammatory chronic low back pain, what you need to ask your patient in the clinical round is, what is the age of onset of the pain? Is it insidious? Does it improve with exercise? Is there no improvement with rest? And does he have nocturnal pain? And if he has at least 4 of these 5 criteria, we can then say that our patient has got inflammatory back pain. In 2009, we got new criteria, what we know as the ASIS, or the Ankylosing Spondyloarthritis Association classification criteria for axial spondyloarthritis. This criteria helps us more to pick up more patients. That's what we want. We want to diagnose early, pick up more patients so that we can treat earlier, because the earlier that we treat, the better prognosis we will have. So what do these criteria say? Again, it's very much similar. In any patient having back pain more than or equal to 3 months, age of onset less than 45, we have got 2 arms. The imaging arm says, if you do imaging and you find sacroiliitis, what type of imaging? This asterisk takes you here. Sacroiliitis on imaging may be active inflammation on doing a magnetic resonance imaging. If you see active inflammation here, as is shown here, these are spots of active inflammation in the MRI of the sacroiliac joint. This is active sacroiliitis. This is highly suggestive of spondyloarthritis. Or if you do a plain X-ray and you find definite radiographic sacroiliitis according to the modified New York criteria that we just mentioned previously here, then you need 1 or more SpA feature. what are the SpA features? These you should know very well. The SpA features include inflammatory back pain, arthritis, peripheral arthritis, enthesitis, particularly of the heel, uveitis, dactylitis. Dactylitis means inflammation of the digits, psoriasis or a history of psoriasis, Crohn's disease or any form of colitis, good response to non-steroidals, family history of spondyloarthritis, HLA-B27 positive, and an elevated CRP. So you have sacroiliitis, either on MRI or plain X-ray, then you need one or more of these SpA features. Other patients, we do not find sacroiliitis, and in this patients, we used to lose them previously. Now we have another arm. Here we look at the HLA-B27. If it is positive, then you need 2 or more SpA features, not only one. And this, here again are the SpA features. And in this way, as you see, we get more patients included. So these are the entry criteria: back pain, imaging arm, clinical arm, and these are all the features. For the imaging arm, you need 1 or more criteria. For the clinical arm, you need 2 or more criteria. And this is just another way that we put forward our criteria. And as we said, we've got the axial spondyloarthritis and also our peripheral spondyloarthritis. What is the peripheral spondyloarthritis? This is arthritis or enthesitis or dactylitis, in which case our patients here do not have the axial features in the beginning. They present with peripheral manifestations such as arthritis, enthesitis or dactylitis. Here we need 1 or more SpA feature, or if they present with these peripheral manifestations, we need 2 or more of the other SpA features. So if it's arthritis, enthesitis or dactylitis, we need 1 or more SpA feature being uveitis, psoriasis, colitis, preceding infection, genital infection, GIT infection, HLA-B27 positivity. And here, sacroiliitis on imaging is just one criteria put together with the peripheral manifestations, or 2 or more SpA features, and in which case you will take into account peripheral arthritis, enthesitis, dactylitis, inflammatory back pain, any history of inflammatory back pain, and a family history of SpA. So this is the classification: axial SpA and how we include our patients, and the peripheral SpA and how we include our patients. Here we have this entry criteria, in which case we will have to choose between the SpA features. And in this way, what is the aim of the new classification criteria? That we include more patients and we pick up more patients. And here are just pictures showing you the peripheral arthritis of the small joints, the enthesitis of the heel, the dactylitis that we may see, and the peripheral affection of the joints, in which case here we have hip disease. And once again, looking at all the extra-articular manifestations, psoriasis. What is psoriasis? You will be taking it in dermatology. The extramusculoskeletal manifestations may include skin psoriasis, which is an inflammatory skin disease, aortitis, inflammation of the aortic root, non-specific urethritis, peripheral arthritis in any form, conjunctivitis, anterior uveitis. Anterior uveitis is very, very important. It may be a presenting feature in many of our patients. Inflammatory bowel disease, peripheral arthritis. Often it's lower limb affection, often it may be oligoarthritis, and also dactylitis is another manifestation. For psoriatic arthritis, I'm not going to go into a lot of details. I just want to tell you that we've got also classification criteria which help us to pick up our psoriatic arthritis patients. Here, our patient must have inflammatory articular disease in any form, either peripheral joint, spine, or enthesial disease, and have a score of more or 3 points. We've got, what are the points? Here are the points. First of all, he has to have evidence of psoriasis, either current psoriasis or a history of psoriasis or a family history of psoriasis. If he's got current psoriasis, he gets 2 points, or if he has a personal history or family history, it's 1 point. We look for psoriatic nail dystrophy, any form of pitting or onycholysis or hyperkeratosis, he gets another point. Negative for rheumatoid factor, 1 point. Dactylitis, swelling of the entire digit or any history of dactylitis, 1 point. And radiologic evidence of new bone formation or any form of articular erosions or ossification, he gets 1 point. And these as a classification criteria for psoriatic arthritis. What's the etiology of spondyloarthritis? We don't know the exact etiology, but we know that it's interacting environmental and genetic factors bring about a chronic inflammatory response. We also know that the main genetic factor is HLA-B27. Maybe also the intestinal microbe seems to play an important role. And we know that there are many cytokines that are involved in the inflammation of spondyloarthritis, particularly tumor necrosis factor alpha, interleukin 17 and interleukin 23. And that is why now we have got agents, biological agents targeted against these 3 cytokines, and by blocking these 3 cytokines we are doing much better in our treatment. So when you think about the pathogenesis of spondyloarthritis, know that we need a genetic background, we need an environmental trigger, we need some sort of abnormality in the innate and adaptive immune system. We need disturbances in the gut microbe and some sort of biochemical stress. When all these come together, our patients will get sustained inflammation, and this will present with sacroiliitis, spondylitis, enthesitis, and of course, once there is inflammation, there will be fibrosis, and the fibrous tissues will lead to new bone formation, and as we'll see, this will continue to complete ankylosing of the spine. So this is one way of thinking of the etiopathogenesis, that we've got the initiation of the inflammation. Many cells are involved, both in the innate immune system and in the adaptive immune system, bringing about activation of many cytokines, and these cytokines bring about a lot of inflammation. What is the risk of developing ankylosing spondylitis in the relatives? Well, the risk of developing ankylosing spondylitis in a first degree relative is about 8%. Second or third degree relative is very much lower. And as you see, here's the sequence of events. Inflammation, if we leave the inflammation unchecked, it repairs. The repair is by new fibrous tissue. New fibrous tissue leads to more new bone formation, and this is where we get the full-blown ankylosing. How does our patient present? As I said, the common presentation is chronic back pain and stiffness, particularly in the lumbar region and the pelvis, and any part of the spine may be involved. Inflammatory back pain is the hallmark feature of spondyloarthritis, younger age of onset, and as I said, more than or equal to 3 months of complaining. Morning stiffness, more than 30 minutes. Pain and stiffness improves with exercise, not with rest. Awakens the patient at night. Nocturnal pain, alternating buttock pain, and good response to non-steroidals. And we need 4 out of these 5 features to diagnose our patients. What are the musculoskeletal features? If we group them all together: sacroiliitis, inflammation of the sacroiliac joint; spondylitis; enthesopathies in whatever form, enthesitis, either Achilles tendonitis, plantar fasciitis. As you see here, we have the erosive enthesitis and the trochanteric enthesitis. Asymmetric peripheral arthritis, as you see here, it's large joint involvement. And of course, tenosynovitis and asymmetrical peripheral arthritis, as we said. What are the extra musculoskeletal manifestations? You don't have to know the prevalence with the exact percentage, but you should know that they include dactylitis, skin psoriasis, conjunctivitis, anterior uveitis, aortitis, IBD, non-specific urethritis, peripheral inflammatory arthritis, and peripheral enthesitis. Also very important, in addition to the extra articular manifestations, we've got our patients can get a lot of comorbidities, particularly hypertension, hyperlipidemias, and obesity. So we have to ask about this in our patient. And the patient that you will see in the round will be a classical male patient presenting with insidious onset of intermittent or persistent low back pain, and as I said, he will have the manifestations of inflammatory back pain. Also, our patients may get chest pain very commonly, and why is this? This is because of the thoracic involvement that can lead to the anterior chest pain, because we said all the axial and central joints are involved. Peripheral arthritis, as I said, is common, and heel pain is common. So our patients have got a lot of pain. What are the extramuscular skeletal manifestations that you should be particularly wary of? Aortic insufficiency and ascending aortitis, conduction defects, kidney secondary amyloidosis, and IgA nephropathy. Do not forget the anterior uveitis, pulmonary manifestations, including upper lobe fibrosis, restrictive changes, GIT manifestations, as we said, and very importantly, many of our patients may have asymptomatic colitis, so we should be aware of this. This is just a picture to show you the acute anterior uveitis in our patients. It's often of an acute onset, maybe unilateral, presenting to the ophthalmologist, not to us. Often there is spontaneous remission, but the problem is it's recurrent and very high relation to HLA-B27. This is a picture of the peripheral arthritis that we see in peripheral spondyloarthritis. As you see, asymmetrical affection of the knee joints. This is a picture showing you the enthesitis that is very common in spondyloarthritis patients. Skin manifestations, particularly important, is of course the psoriasis, but we should not forget erythema nodosum, pyoderma gangrenosum, and keratoderma blennoragicum can also occur. This is a picture of a patient having psoriasis, as you see the plaques here. This is a picture of erythema nodosum. Pustulosis palmaris is another manifestation, and here you see the nail changes that are very common in patients having psoriatic arthritis and nail dystrophy. Here is another classical picture of nail dystrophy and that we see in our patients with psoriatic arthritis. And here again is the dactylitis, the sausage fingers that we can see in our patients having peripheral spondyloarthritis. These are the typical gut lesions that we can see in patients having IBD-related spondyloarthritis. How do we work up our patients? As I said, history is of the utmost importance. Doing a very good examination, labs, CRP and HLA-B27, looking at the sacroiliac joint films, and of course doing magnetic resonance imaging of the sacroiliac joint. HLA-B27, as I said, is present in a big percentage of our patients, but take care that many patients, many normal individuals, not patients, may also have HLA-B27 and not have spondyloarthritis. So we should use it in the context of our clinical picture. Also, as I said, other genes may be involved, and very important is that we always do acute phase reactants, because CRP is important. It's important for disease activity. It indicates the active inflammation, and as I said previously, it predicts radiographic progression in your sacroiliac joints and the spine. So this is putting it into perspective. The symptoms, inflammatory back pain or any, and on top any other symptoms, as we said. Imaging is important, MRI and plain X-ray. Lab is important, and of course a good response to the non-steroidals. Genetics, HLA-B27, take a good family history, ask about predisposing concomitant diseases such as psoriasis, Crohn's, and other infections. Physical examination, you will be taught this in the rounds. I'm just putting it here to for the sake of completion. We've got a set of tests that we test for the range of motion of our spine and the sacroiliac joint. We've got several tests that you will be taught in the round. This is just an example of how we test for sacroiliac tenderness over the posterior superior iliac spine. This is a test that we do to see the range of mobility of the lumbosacral spine, known as the Schober's test. And you will be taught these tests in the round. This is a test that we do to see the range of motion of the cervical spines, known as the occiput to wall test. Normally we know that if we stand against the wall with a feet barefoot against the wall, our occiput should touch the wall. Here, as you see, there is a very big difference between this range. The more is this distance, the more severe is our patient, and we also use it to follow up our patients. When we give treatment and the patient gets better, the distance gets less. This is the classical occiput to wall test that we see in our patients, and another example of the Schober test. This is, as I said, the end stage severe kyphosis that we do not want to see in our patients. So lab test HLE-B27, as I said, and don't forget also to do your routine tests, including the CBC, where you might find mild anemia. We do pulmonary function tests in very severe patients. As I said, the central joints are involved, and we get diminished vital and total lung capacity. And of course, this has an effect on the quality of life of our patients. Rheumatoid factor is usually negative, and as I said, CRP is elevated. This is just to reiterate that imaging is important. What are the imaging that we do? As I said, we do plain x-rays in the beginning. It's still the gold standard to assess structural changes, but we know that magnetic resonance imaging, with its ability to detect active and structural lesions early after symptom onset, is considered the optimal imaging modality in our patients where we suspect spondyloarthritis. And as you see here, in various images, you see the active inflammation. Here it's evident in the plain x-ray. Here it's evident on doing the magnetic resonance imaging. So conventional radiography, as I said, it's got the limitations. Here it's this is a very severe ankylosing spondyloarthritis, radiographic axial spondyloarthritis, or what we used to call ankylosing spondyloarthritis. This is a very severe case. We do not wait anymore for these very severe cases. We want to pick up our patients earlier. This is the imaging that I spoke about early on in the lecture. You will be taught this. It's got various grades. Grade 1, very mild, 2, 3, and 4 is the very severe radiographic imaging that we see in the conventional images. Syndesmophytes. What are the syndesmophytes? This is the new bone formation that we, after the healing and the repair occurs, we get new bone formation. Here you see the red arrows. These are the bridging syndesmophytes, and then the spine becomes one whole piece, as you see. It's what we call the bamboo spine, the progression. Here it's just the beginning. If we do not follow up our patient, our patients progress and they get syndesmophytes. That's in contradistinction to the osteophytes, which are vertical. Here, which are horizontal. Here you have the vertical new bone formation. So this is the vertical. The osteophytes are occurring in osteoarthritis, and they are horizontal. Here it's the vertical. This is just another picture showing you the severe sacroiliitis on the plain x-ray. Here is the hip involvement, showing you the severe hip involvement that is present in our patient, as well as the sacroiliac involvement. That's on a plain x-ray, conventional imaging. Here is a picture of the bambooing of the spine. And again, the MRI imaging showing you these white spots are active inflammation. And the structural changes, we see subchondral sclerosis, erosions, metaplasia, bony bridges, and in the spine as well, as I showed you, syndesmophytes, fatty metaplasia, and ankylosing. Another picture showing you the classical active inflammation and the classic active inflammatory sacroiliitis. Once again, showing you the inflammation. In the spine as well, active marrow edema, active inflammation at multiple sites along the spine. So, as I said, spondyloarthritis is a clinical diagnosis. We have to diagnose the patient clinically. We get the clinical relevance of our symptoms. This leads to diagnosis of axial spondyloarthritis. We do have our classification criteria, as I showed you, but they are not meant for diagnosis. They are meant for other research purposes, etc. And for you, we diagnose our patients on a clinical basis and putting together all the symptoms of our patients together. When we move on to the treatment, what is our aim when we treat our spondyloarthritis patients? As you see, our patients have a lot of pain, so we need to control pain, maintain maximal skeletal mobility, and prevent deformities. These are our aims. These are our goals: to control the symptoms, control the inflammation, prevent progression of structural damage, preserve normalization of function as much as we can, and keep our patients active, that he can go to work, he can participate as a normal individual in his daily activities and have a good long-term quality of life. How do we do this? It requires a combination of both non-pharmacological as well as pharmacological treatments. We should not forget the non-pharmacological strategies. We should educate our patient. This is a lifelong disease. He's going to be living with the disease. He needs to know how the disease will affect him. We should encourage lifestyle and behavioral changes. We should help him also know how he can self-manage himself. We should always let him be included in an exercise program. Physiotherapy is a very important part of the treatment, because the more active the patient is, the less inflammation he will have. So, what is the physiotherapy interventions? Any home-based exercise therapy is enough, but we say that the best therapy is hydrotherapy, and daily home exercises is better. And of course, SpA therapy is also very good. What are, in addition to the non-pharmacological strategies, what are the licensed drugs that we have? Our number one drug that we start off, as you saw, there was a lot of pain. Our number one drug is the non-steroidal anti-inflammatory drugs. We start off with that. Then, if we do not get optimum improvement, we progress to the biologic DMARDs. As you saw in the etiopathogenesis, a lot of pro-inflammatory cytokines are involved in the inflammation, including tumor necrosis factor alpha. So we block the tumor necrosis factor alpha by using tumor necrosis factor alpha inhibitors. Another important cytokine was the interleukin 17A. So we use interleukin 17A inhibitors. Now we have got new drugs as well. Drugs that also target other agents, small molecules known as JAK inhibitors. So we've got non-steroidals, biological agents, and small molecules as well. So in addition to using our drugs, we reiterate again that all patients should be involved in physical therapy. Our number one drug that we use is non-steroidal anti-inflammatory drug. Any non-steroidal may be used. For example, indomethacin in a high dose, 25 to 50 milligrams 3 to 4 times daily, is the most commonly prescribed drug. Do we use disease-modifying anti-rheumatic drugs? Yes, we do use them, but only in peripheral arthritis. They have no role in axial spondyloarthritis. So we may use sulfasalazine in a dose of 500 milligrams to 1 gram twice daily with meals if we have peripheral arthritis. And we also may use methotrexate if we've got peripheral arthritis, not in axial spondyloarthritis. We do not use systemic steroids in axial spondyloarthritis, and if we use them with extreme caution, because they may cause complications, particularly they may aggravate osteoporosis and lead to fractures. Sometimes we do resort to intra-articular steroids, particularly if we have one single joint which is very, very painful and very swollen. But we do not resort to it the whole time. The biological therapies, as I said before, include the tumor necrosis factor inhibitors such as etanercept, adalimumab, golimumab, interleukin-17 inhibitors such as the secukinumab, and the JAK inhibitors such as the tofacitinib. So this is the toolbox that we have. Number one, non-steroidals, physical therapy, tumor necrosis factor alpha, interleukin-17s, and the JAK inhibitors. And this is how you should think of when you look at the management of axial spondyloarthritis. In both axial and peripheral disease, we use non-steroidal anti-inflammatory drugs. In peripheral disease, sulfasalazine, methotrexate. We may resort to 1 or 2 injections of local corticosteroids. Biological DMARDs include tumor necrosis factor alpha, interleukin-17s, and the JAK inhibitors. Don't forget the non-pharmacological therapy, and very rarely do we resort to surgery. So these are the 2 approved therapies that we have. This is just an algorithm that has been put forward to us, how we look upon the treatment of spondyloarthritis. Always we need, as I said, a diagnosis put forward by a rheumatologist, and if we have an elevated CRP and a positive MRI sacroiliac joint, and then we proceed and we look at the we give the non-steroidal anti-inflammatory drugs. As I said, all patients, we start with the non-steroidal anti-inflammatory drugs, and we use at least 2 non-steroidal anti-inflammatory drugs over 2 weeks. In patients with predominant peripheral manifestations, we may give a shot of local steroid injection if appropriate. We may use sulfasalazine only in peripheral manifestations. If our patient persists with high disease activity, then we proceed onto our biological agents. So overall, we should know that axial spondyloarthritis in general is a severe disease. It's got diverse manifestations. Our optimal aim is to maximize health-related quality of life, control symptoms, control inflammation, keep our patient active, keep our patient participating in his daily activities. Optimal management is not only pharmacological, it's a combination of non-pharmacological and pharmacological treatment, and it's of course always taking into account the best care for our patients, and also taking into account that we should individualize our treatment. This is an algorithm that we have. I don't want you to be mild boggled by it. It's just very straightforward. We, as I said in the beginning, we need a clinical diagnosis. We start, if our patient is symptomatic, we start with non-steroidal anti-inflammatory. We titrate. We don't get a good response after 2 courses, after 4 weeks. Then we have to see, is our patient having mainly peripheral symptoms? We proceed, as I said before, axial symptoms. We proceed, as I said before, he's getting a good response. We continue, and if he's getting a very good response, we may even slowly start to bring down the therapy. If he's not getting a good response, we may accelerate therapy. If our patient gets a good response on non-steroidals from the beginning, we continue and monitor our patients. So non-steroidals are our number 1 agents. These are the different dosage of the biological DMARDs. Most of our biological DMARDs are given either subcutaneously or some by intravenous infusion. Etanercept, as you see here, is given by subcutaneous adalimumab. They are all monoclonal antibodies made by recombinant DNA engineering. As you see at the end, they all have mab, so it's adalimumab because they are monoclonal antibodies. Some of them are humanized, some are partly humanized. These are the different doses and the different applications that we have. And again, just to reiterate that as you see here, tumor necrosis factor alpha may be used in different phenotypes, in the axial, in IBD, in psoriasis, and in uveitis. Others may not be used. For example, interleukin-17, we cannot use it if we've got uveitis. We can only use tumor necrosis factor alpha if we have got uveitis. So some of our biologicals may be used across the different phenotypes, others not. So tumor necrosis factor alpha is one biologic that we may use across the different phenotypes. So that again is important for you to know. This is I think where I want to stop, and thank you for your attention, and wish you good luck in your exams. Thank you.